It's 12:02 and I know we have a lot to cover today, so I don't want to take up too much time. Is that all right with everyone? And people will continue joining, but it's good to see everyone. So welcome everyone. I'm Marie Abraham. I'm the Vice President of Programming and Publications at the Institute for Patient and Family-Centered Care. And today we are joined by two experts in this topic, supporting family presence and participation to improve safety and quality. Lisa Raffoul, she is the implementation lead at the Essential Care Partner Support Hub, which is based in Ontario Caregiver organization. And if you don't know the Essential Care Partner Support Hub, they have a ton of wonderful resources and tools. And then we are also joined by Shanne Keeny. She's the Director of Patient and Family Experience at the Johns Hopkins Hospital. And given the number of people who registered, which is amazing, it's obviously a topic of great interest. So it's just wonderful to see everybody here. And I see people are chatting in their names and their organization and where they're located. So that's perfect. So we are recording this conversation so we can share with those who registered just for the recording and not for the live session. And we'll post it to our website as soon as it gets cleaned up and ready to go. And so we love seeing faces, but if you prefer, you can go off camera, but we really do love to see faces. So you can do what you want. Next slide. So we want to thank our PFCC Connect sponsors, Emory Healthcare and University Health. We also want to thank our presenters from the Ontario Caregiver organization and from Johns Hopkins. So without the support of Emory and University of Health, we could not continue these informative, inspiring conversations. Next slide. So we do have group agreements. We know we want to keep our conversation very interactive and informative. And so the presenters will be sharing slides to set the context. We have a video also inserted. But this is just giving information to get the conversation started. And we'll dive into the discussion Q&A portion as soon as we're done with that. We just want to remind everybody of the group agreements, be present as possible. When we move into discussion, it would be great if you could go on video. Participate actively. We really encourage you to be curious and ask questions, but also share your experience, perspectives, and any challenges you may have faced. And you can either chat in your questions or ideas or raise your hand and we will call on you. Let's share space. So because we have so many people joining today, it's going to be tough to get to all the questions, but we're looking forward to it. And then embrace a learning and growth mindset. So you bring expertise and we have a lot to learn from each other. It's not just us and our two experts, it's everybody in this group. And then we hope you enjoy the conversation and have fun. Okay, next slide. Great, thanks, Matt. So thanks to all who registered and who shared questions and comments when you did register. Here are some of the issues that we learned about, what you are most interested in. It's not, we had so many different things, so we just kept it to this slide. But how can we encourage leaders and staff to support family presence? What strategies are helpful to include families on multidisciplinary rounds? What can we do to manage staff resistance to the policies on family presence? What are the best practices to effectively educate staff and essential care partners and families to participate? And then what are other strategies we can implement to support staff to recognize caregivers as essential care partners and not visitors? And then what can we do to manage a situation when the caregivers, care partners disagree with the patient priorities? So hopefully we'll get to many of these issues today. And with that, I'm going to hand it over to Lisa.
So much, Marie, and I'm just thrilled to be here on behalf of the Ontario Caregiver Organization and share information from the Essential Care Partner Support Hub, where I'm an implementation lead. A little bit about the Ontario. Matt, can you switch the slide, please? A little bit about the Ontario Caregiver Organization. We are a not-for-profit organization funded by the Ontario Ministry of Health, and that's Ontario, Canada. Simply put, we exist to improve the lives of Ontario caregivers. We offer programs and services to caregivers, including a helpline that is available 24 hours a day, 7 days a week. Next slide, please. Caregivers are at the center of everything that we do. We engage them to share their insights, and this is done in many ways. For example, through our caregiver advisory panel and working groups. We also commission research to better understand the experiences of caregivers in Ontario, as well as the perspectives of healthcare providers on partnering with caregivers and the impact that caregiving has on care recipients. These insights guide us in everything else we do, including providing training and support to the healthcare system, increasing public awareness of caregivers, sharing information with caregivers and the public, and offering many direct-to-caregiver programs and services. Next slide, please. A caregiver is chosen by the person and can be a family member, friend, or a neighbor who provides unpaid physical and emotional support to a care recipient. Formally, a caregiver is sometimes known as an essential care partner, designated care partner, essential caregiver, or family caregiver. These designations are given by organizations, often along with training and identification as part of caregiver inclusion programs. As I mentioned, essential care partners are chosen or identified by the care recipient or the substitute decision maker. They are then formally recognized by the healthcare organization. And one of the fundamental principles is that one of the fundamental leading practices, I should say, is distinguishing between essential care partners and visitors. Both are equally as important to the person. But essential care partners are different from visitors or primary or emergency contacts, other family members and friends, or even more generally, the person who may be accompanying the person to an appointment. In some cases, the essential care partners also act as the substitute decision maker, but not always the case. If a substitute decision maker is making decisions on behalf of the person, they may designate someone else other than themselves to be the essential care partner. The essential care partner is that constant person who is actively involved in patient care, including supporting decision making and care coordination. Next slide, please. So now I want to share a video that we're very proud of at the Essential Care Partner Support Hub and OCO. It shares stories and testimonies from caregivers. And when you watch it, I'd like to ask you to please reflect on a couple of questions. How does caregiver involvement improve care? And according to the caregivers and the professionals you hear from, what contributed to the positive experiences? And perhaps those might spark some discussion points later on as well.
My caregiving journey started with my son. He had some seizures. They didn't think that he was going to make it.
Dad was diagnosed with dementia in 2014. Literally at that moment, everything was going to change.
My wife Lynn and I started to notice that she was just confused. Sure enough, dementia was in the picture.
14 months old, was found on the pond over there, near drowning, and in 5 days he woke up different child. So
it started off with my brother, diagnosed with Duchenne muscular dystrophy at the age of 6. The caregiving role was kind of thrusted upon our entire family. And our mom was diagnosed with stage 4 lung cancer. Although I want to feel like it's made me like the person who I am, embracing the role of being a caregiver, I feel like, hey, maybe I could make another person's like day a little better.
My experience here was that she had a terrible fall and was taken by ambulance to the hospital. Went to go in the hospital and they said, oh no, there's no visitors allowed back there. I said, well, I'm not a visitor. This isn't somebody coming just to say, hi, I hope you're okay. This is someone there to make sure she can respond to questions. And that wasn't allowed to happen.
well, the caregiver is 24 hours, 24/7 for years, months, or whatever, and know that person. The person that you look after relies on you, trusts on you. So who is that person to give comfort? We are.
My mom was diagnosed with early onset Parkinson's about 14, 15 years ago now. I never really considered myself a caregiver until I had a provider actually kind of call me out. I was like, no, you're actually the caregiver, and I want you to recognize that, I want you to acknowledge that, and I want you to take that role into ownership. What a caregiver looks like can be so diverse, can be so different, it can be so unique, and so to really be open, to support them, and to understand that they are an integral part of their care, and so they need to be part of these important conversations in terms of the continuum of care and how can we make sure that the well-being of the person is as best as it can be.
I'm very lucky and very grateful that we've had such positive experiences from staff at hospital. For them to be open and empathetic, knowing that we're trying to help them and make sure that Dad receives the best care, were really important to us, and they stay with us.
My partner had 2 strokes. I always say when I go into a hospital, I am his spouse, I'm his caregiver, and I am a substitute decision maker. Caregiver first. They objectively can see their person. The caregiver also saves a ton of time in the medical system by being able to share that story, by being able to identify when something's a problem and when it isn't. More importantly, the caregiver is the implementer of any action plan. So when you omit the caregiver from a conversation, you are sub-optimizing without question that patient's health.
I think it's important to have empathy for caregivers because I think of the conversations I have with those folks as they come through the hospital. When I talk about social work and discharge planning, I look at sort of where the person was before their stroke and hospitalization, and I look at where they are leaving. And when I mesh it all together, I want to see kind of the things that are missing, right? I can't do that unless I know who's in this person's life.
We need to start looking proactively at how to care for caregivers. And I think part of that is simply just listening to them and including them in the care planning. Because you can come up with a care plan and think it's like the greatest thing in the world, but if their caregiver can't do it, then it's pointless. I truly mean that we cannot care for the patients without the caregivers.
They need more than the medication. They need that love, that comfort, that security that somebody cares.
Burnout is real for people who are caregiving, and just, I was asking them, like, how are you really doing? Like, really, like, how can I help you? And as a caregiver, accept the help.
The effectiveness of caregivers in terms of creating fewer healthcare problems has been proven over and over again. It's got to come from a place that says we value caregivers and see them as critical to our success in treating patients.
I don't have any regrets to the way that I cared for him.
I was just a daughter taking care of my dad, who was my best friend. So to identify as a caregiver, knowing that there are other caregivers out there is really important.
I go and I'm like, no, I'm a caregiver. And I present myself that way in my conversations with my mom's providers, because I find that that really changes the way that the conversations take place.
The relationship with my brother continues to evolve. There's been moments that he tells me, it's like, hey, thank you. To be able to hear that, I know that they are appreciative of what we do as their advocate and carer.
We, as a caregivers, we do an amazing job, and we have to be proud of that. And yes, I'm proud to be a caregiver.
Just take a pause to say, wow. I know the first time I saw that, it really hit home, and it was very profound that I saw some of the comments in the chat. And thank you so much for your very positive comments. And many of you had said this is something that I can relate to. And I believe Bev has shared the link in the chat. And of course, afterwards, the link can be shared as well. So what do we do? How do we get this done? Matt, if you could switch. Yeah, thank you. First and foremost, understanding how caregivers improve care. Of course, their involvement can improve trust, collaboration, and communication among the healthcare providers and care recipients. There can be misunderstandings or misperceptions if caregivers aren't involved and aren't shared information. And one of the core principles at IPFCC is information sharing. Sometimes caregivers provide interpretation services, or they can take notes if things become overwhelming or hard to understand for the person. They can ask questions that can bring some clarity to the circumstances. Caregivers are really the thread that provides continuity of care over time and across multiple settings. They often hold the care recipient's story and are able to share important information about past events and decisions, supporting integrated care across settings and very important, during transition points in the system. They are often responsible for implementing the care plans. And really, they provide medical information that can be as important and dependable as the medical record. And through their vigilance and knowledge, they can help prevent medical errors and insufficiencies. Very important point. Next slide, please. So all of this translates to some very real outcomes for care recipients as well as healthcare providers. We see there can be lower admission rates, reduced falls and falls-related injuries, reduced psychological comorbidities, decreased length of stay in ICUs, improved adherence to medication, increasing a better understanding of discharge planning and follow-through, sustained cognitive function for older adults, and earlier detection and treatment if there's any cognitive changes. And if from your experience, if you can think of situations where the caregiver has said something just isn't right. And so they are often the people who can detect that very early on. Next slide, please. So to know what might be helpful, let's imagine for a moment that we're a caregiver who doesn't feel valued. So we want to go, you see from here, often even now, as we work toward increasing essential care partner or including caregivers, they might be saying, am I a caregiver? What the heck's an essential care partner? Are my contributions to care helpful and appreciated? Or am I in the way? How am I expected to contribute? What's most helpful for me and important for me to do? So when we talk about valuing caregivers, we are assuming that we know who caregivers are and that they identify with that role. So this uncertainty, we want to move from here. Next slide, please, Matt. to hear, where people are confident in saying, I am a caregiver and or an essential care partner. I know that what I need to do, and I can plan for it, and I know that my contributions are valuable to the team. Next slide, please. So again, how do you get all this done? Where do you start? Who can help me? Well, in March 2023, in partnership with Ontario Health, the Ontario Caregiver Organization launched the Essential Care Partner Support Hub. This initiative built on work that we had already been doing alongside health system partners. It began at the outset of the pandemic when we started a learning collaborative with a focus on the safe presence of caregivers in hospital and long-term care homes. This has evolved from a focus on presence to an emphasis on inclusion across settings. So the identification, inclusion, and support for caregivers are the three main pillars that we work under, and there is a team of implementation leads such as myself that provide resources and tools, ongoing coaching, and connection to peers. We are your go-to people to help you and support you along the way, and we meet you where you're at. It's not prescriptive where you must do this or do that, or you know, this is the absolute starting point. We meet you where you're at. Next slide, please. We've developed a number of resources to help support organizations, an implementation toolkit, which is a guidebook. And I know when I was working in hospital and working on such a program, this was very helpful to me. We have an evidence summary. It speaks to the why and the benefits for both caregivers and healthcare providers. And that information is really helpful when you're running into some resistance from staff. We have a journey map that shows kind of the journey of a caregiver. I think this one really reflects a hospital experience. We have a poster that can graphically identify many roles of what an essential care partner or caregiver does. And so it helps them relate to realize that they're a caregiver, as well as a template for caregiver ID badge. Next slide, please. Another resource that we have is the Essential Care Partner Learning Collaborative. We meet every 6 weeks. It's a forum for care provider organizations committed to enhancing caregiver engagement. We share knowledge, challenges, solutions, and tools with a focus on enabling essential care presence, caregiver ID implementation, building a culture that values and recognizes caregivers as partners on the care team. This is a very interactive group. There's leaders and caregiver partners from a range of organizations such as hospitals, long-term care homes, Ontario health teams, and community organizations. Next slide, please. Over to you, Shane, I believe. Yes.
Thank you, Lisa, and thank you for sharing that video. That was a tearjerker, and I'm looking forward to sharing it with our team. So on this slide, just a short bit of history to start. The Johns Hopkins Hospital was founded in 1889 with the University and School of Medicine following in 1893. And we're still in the original location today. So the top of this slide is the dome building that you might recognize as the Johns Hopkins Medicine logo. And then the campus has expanded in the area around this building. And so the bottom photo is the front door of the hospital today. And you can't see the dome on that, but it is all connected. All those buildings are connected. Next slide. William Osler was one of our founding fathers of the university and the hospital, and he's often called the father of modern medicine. And as you can see from the quotes that are attributed to him here, he's also a very patient-centered guy. So we're really proud of that person-centered foundation that he built and helped establish many, many years ago, and we try really hard to live up to that legacy today. Next slide. For anybody who has already gone through the IPFCC toolkit for partnering with patients and families to enhance safety and quality, you might recognize this diagram. I included it today because it really resonates with me, and especially that first step, which is create a collaborative decision-making team. I'm really fond of saying that we should include the patient and family voice as early and as often as possible, and reminding people that they are key stakeholders in the business of healthcare. There's really nothing more frustrating, although we all have the best of intentions, than spending a lot of time on a project that you think our patients and families are going to love, and then later finding out that we missed the mark in some way. It's frustrating for our patients and families. It's also frustrating for the staff that spent a lot of time and, again, those good intentions working on it. So including patients from that very first step of the wheel and truly including them in co-design is living up to that definition of patient and family-centered care, where we're doing with our patients and families instead of doing for them or doing to them. And we have the ability, and we should embrace that they are part of the healthcare team, whether that means participation in care or collaboration to drive improvement and other hospital initiatives. Next slide. So like most health systems during the COVID-19 pandemic, Johns Hopkins Medicine visitation went basically to 0 or to by exception only. Our patient and family advisors were actually really instrumental in moving the organization's stance to establish a tiered visitation policy that did allow care partners for all patients, including patients with coronavirus. So our advisors collaborated in that development of that tiered policy and included defining what a care partner is, which you see on this slide, as compared to a visitor. And then post-pandemic, we retained that definition, and our PFAs also participated in the development of that post-pandemic policy as well. So it's one thing to have a policy and a definition around this, and then I think it's a totally different thing to understand if we live up to that intent or live up to that expectation. Next slide. So although our intent wasn't to assess how well we're upholding that expectation of the differentiation between care partner and visitor, during Patient Experience Week this year, we asked our patient and family advisors to share stories related to the 4 core principles of patient and family-centered care. And then we shared those stories across the organization in our daily electronic internal news platform. So several of our PFAs shared stories about their experiences as care partners, really demonstrating that adherence and importance of the difference. So I don't want to read them to you, they're here, but I'll just pause for a few seconds so that you can have a couple minutes to see them and get a feeling for their perspectives. We really feel like these are great testimonials to our commitment to our patients and families as partners in their care. Next slide. So not only asking patients and families, but we also recently asked staff about the impact of having care partners at the bedside. So these are some of the things that our staff shared with us. So again, I'll give you a few seconds to just review what they've shared. So we find ourselves really fortunate and grateful that our staff have embraced and appreciate our care partners and really involve them in the care and involve patients as much as possible. The last quote on this slide is actually from one of our Johns Hopkins School of Nursing colleagues, who includes our patient and family advisors in delivering curriculum to the nursing students. And I wanted to make sure that we share our PFAC structure and the different ways that we incorporate the patient and family voice. If we go to the next slide, please. This is our current, what I refer to as our current PFAC ecosystem. We have 8 different patient and family advisory councils, and that includes over 200 members. Then representatives from each one of those councils also participates in what we call the JHH PFAC Collaborative. So a couple of representatives from each one come together about quarterly as the collaborative, and then all of them operate under the same PFAC charter. We submit our PFAC minutes through the Patient Safety and Quality Improvement Committee as oversight. So we have that quality and safety connection. And then this is just the Johns Hopkins Hospital PFACs. There are additional PFACs at our entities throughout the health system. And we also have a Johns Hopkins Medicine PFAC collaborative, which is similar to the JHH PFAC collaborative, and brings representatives from across the entire health system and each entity PFAC together as well. Next slide, please. In addition to our PFAC meetings, we also get really creative with other ways to incorporate the patient and family voice. So if we don't have a group that is maybe specific enough for a particular topic, or if we have a department that might be interested in developing their own PFAC, we hold what we call patient and family cafes, which is really a focus group. It can be a one-time group. So if it's a specific topic, it might just meet one time and talk about that topic and be done. Or if it's in preparation to maybe develop a PFAC, we hold it a few times to identify interest and build membership for formalizing that PFAC. And then it also gives the staff who are going to be supporting that PFAC the space to learn how to best manage it. If we have topics that apply to all of our patients, we typically take that topic to our JHH PFAC collaborative, but sometimes we do have topics that apply to some of the groups and not all of the groups. Or we might need feedback before that PFAC collaborative meeting is going to occur. So what we do in those cases then, to be respectful of presenter time, is maybe create a subgroup with representatives from the impacted areas. Those subgroups, similar to focus groups, they might only meet once. They might regularly have a short time commitment. So maybe they're going to meet once a month for 3 months, or they might be on call. So our interview subgroup, for example, is one that we call on routinely, but not on a regular schedule, to help interview candidates for key positions within the organization. And as an example, they recently helped with the search for our chief nursing officer and guest services supervisor. Of course, we also place our PFAs on our councils and committees as regular participants whenever possible. And I just included a small subset of councils and committees that our PFAs regularly participate in that are relative mostly to quality and safety. And then I already mentioned the education initiatives for PFAs. This does apply to the students that we talked about, the nursing students, and then it also applies to staff education as well. What I didn't list here, just as another pathway to hear the patient and family voice, is our virtual advisors group, which is a few thousand individuals who have signed up for sort of just survey type email communication through our marketing team. And we can pull that group as well if we find that none of our other pathways are sufficient. And I think that is my last slide. So Marie.
Thank you, Lisa and Shanne. That I know we went a little bit over time, but that's okay. We've gotten lots of chats. So it would be great to, Matt, you can pull down the discussion slide and let's just jump in. So I don't know if we want to tackle the chat questions first. One thing was training. We didn't mention training. So how do you train for the care partners and the staff?
I can start, Marie.
Sure.
Yeah, so it can happen in a number of forms. Some organizations that we've worked with, instead of hosting a formal training for caregivers, they've developed a guidebook, and the content of the guidebook is different than the patient guidebook that you are probably all familiar with when someone enters hospital. It's about roles and responsibilities. What's the best time to call for information? Because we want to respond to you, but we don't, we might not be as responsive during shift change or other times of day. So there's suggestions in there, who to go to if you have questions. What if you don't agree with something that has been presented or proposed? So, they use guidebooks, and something that one of the organizations came up with was a meet and greet. So a couple of days after admission, sitting down with the care partner, introducing yourself. We want to welcome you as part of our team. What you have to offer is very valuable to us. Here's a few things, and highlight what's in the guidebook. Some people for staff training have done mocks. So on units, so during maybe huddle time, they've gone through a scenario of welcoming a care partner on the team. Others have done virtual orientations. We have e-learning opportunities on our website, and people can log in onto our site, or they have actually downloaded them onto their own systems. New staff orientation, again, virtual, maybe 15-minute information, foundational information. So those are some of the ways that we have provided education or can share tactics for providing education.
Shanne, do you have anything to add?
Yeah, I would say, for our staff, when we first rolled out the policies that differentiated between a care partner and a visitor, we held almost like town halls. We called them stakeholder meetings, where we invited folks to come in and really hear and ask questions about that. And then we have ongoing education through new employee orientation and whatnot. For our care partners themselves, we do put the definitions out on our website, but we really don't expect them to identify themselves as care partners necessarily. We have our clinical team help them understand if they are a care partner. So we don't, when people are coming into the organization, we don't expect them to come in and say, I'm the care partner. Although for our repeat patients, they do kind of learn that, and they will say that, but we don't expect them to identify themselves in that way. We recognize them and help them understand that role.
Great, thank you. Oh my goodness, the chat is really going crazy. Shanne, someone asked about your background. Are you a nurse? What's your background?
No, and if you ask me how I got to patient experience today, you would say, wow. So I do not have any clinical background. I have a bachelor's degree in music, a master's degree in information systems technology, and am pursuing my doctorate in medical humanities. If you want to know how those all connect one day, we should connect offline. I'm happy to do that.
Okay, great. So I'm just scrolling back on the chat. So we talked about training a little bit. People really are very interested in sharing that video, by the way, just so you know. So let's see. So I know, Emily, you had some ideas about training that you've done in that sphere.
Yes, I do. I was both a patient partner and later hired as an employee to onboard and train others. And I found that there were two really essential things. One is basic facts, what kind of an organization this is, what are the different people inside of it and how they interact and so forth. But even more than that is a conversation about what do we do when we're in the midst of sometimes challenging conversations. Because it's important to have good ground rules, but what's the reasoning and the experience behind those ground rules so people get, this is why it's important to do, whatever ground rule 1, 2, and 3 are. That's the main thought I had on that.
Thank you. Irene, you have your hand up. You're on mute.
There, that's better.
Yeah.
We all live busy lives, and as do essential care partners. And I just wonder how you've worked it out, because sometimes their care might be inconsistent and their presence might be inconsistent at the bedside. So that becomes like an opportunity for things not to get done, where someone assumed that they were going to be there and then they're not there. So I just wonder how you approach that in order to make sure that the patient isn't stranded because their care provider got called away for another family emergency.
And I think somebody also mentioned the sandwich problem. If you have kids that you're taking care of at home, and then you have the parents or family members who are, yeah. So Lisa, Shanne, anybody want to handle that one?
You can start. An essential care partner isn't obligated or required to do anything. They are there to enhance and support the care when they can. And so, finding out, establishing, I mentioned the meet and greet, establishing that relationship from the beginning, because you don't want the healthcare staff to feel stressed either if they were depending on that essential care partner to be there, and then, like you say, something comes up, they can't be there. It establishes those communication pathways. So if someone for sure was expected to be there, maybe there was something going on, or they come every day at lunchtime and they just can't come, they know who to call and say, I can't make it today, I'm not feeling well. And Allison, you're saying happy to have do you want to jump in there? Allison is our manager.
Hi. My Zoom has been acting up, so if I spontaneously leave my comments, that's just because my technology is not my friend today. I think that, we really, my response to the chat was for a different comment, but I think that in terms of that kind of balance and struggle, one of the things we oftentimes really work with our organizations that we're working with is talking about having a kind of care partner centered approach to their role as an essential care partner, right? Like it can't be at their expense. It has to be because it makes sense for them, up to and including their own limitations, and what that role might be. So one care partner might have a very active role in physical care, or, even including helping take someone to the bathroom. Another care partner who's just as essential might be there for a moral, spiritual, and emotional support, and both are valid and both are equally important. And there's nuance to that, right? Like this often comes down to those kind of relationships that are created at that point of care. But I think setting up a framework that communicates to the team members that's valid and suitable is really important. The idea isn't that care partners are a replacement for staff. Like, I think that's really important to underscore.
Other questions, or should I keep reading what's going on in the chat? I don't see it, but go ahead, Camilla.
I'm right here. Can you see me now? Can you hear me?
Yeah. Yes.
Hi. My name is Camille, and I am an RN and a clinical medical ethicist and legal nurse consultant. And I put everything together for patient-centered care, and that's where what my role is and what I do in terms of education, consulting, and coaching. And I love what you guys are doing, and this whole caregiver aspect that is so buried in the valuable part of patient care. I'm glad that you're pulling it out so that everybody sees it. My focus is on the patient. And as an ethicist, kind of going along with what Emily said, there are times when as a caregiver, you run into disagreements and dilemmas between not only the caregiver and the patient, or the caregiver and the healthcare staff, but What I found and why I've started to do this is because caregivers and family members tend to minimize those feelings of dilemma because they don't have anywhere to go with it, or to think it's just them, or I have to figure this out. But if you as a caregiver have just that little, feeling of something's not right here, or this isn't going to help the patient, you have to be valued and to go to someone who is very skilled at not just addressing it subjectively. Okay, I think this is a good idea, or I think you're right, or I think, but to do it with an evidence-based foundation so that you are confident. And so the patient too, and then this is the last thing I'll say, I won't talk anymore, but the other thing is the patient having these discussions that you're all talking about, having them with patients before they're not at a decision-making capacity stage. Because if we can raise those discussions with the patients, it's really their decision, whether we as caregivers agree with it or not, right? I mean, I see you, shaking your heads, yes. So it's getting to those discussions very early on, which are, like you said, sometimes very difficult, sometimes very uncomfortable, not knowing what to talk about at what time, or how to talk about that. So I think those are the things that make patients centered. Some patients don't want caregivers, right? I mean, some patients don't want their family to know what they're going through. Or some patients don't want a stranger who we know would be great to help them. They don't want that because they're uncomfortable. So those are the kinds of dilemmas that reduce patient authority for their decision-making capacity. And so anyway, I just wanted to put that out there because that's something that is my focus, but I see as a connection with you because that's something that you guys can identify so quickly and so well. Thank you for listening. Sorry.
No, thank you, Camille. It's great information. I don't know if anybody wants to manage it or respond to it. I know Bart has your hand up, right?
I see Karen too.
So anybody want to respond, or was that a good amount of information?
May I jump in? This
Sure,
is
Karen.
Hi. So a lot of what Camille just said really resonated with me because I was one of those care partners or caregivers, the two terms I think are interchangeable now, that was sat with my dad for 7 months after his lung transplant and just felt like, okay, I was there to be his care partner, but I didn't have a clue what to do or how to be effective. And I was constantly feeling, blindsided, confused, worried, and all, just all of those things. And he ended up passing away from multiple infections, hospital infections. And that's what really claimed his life after having a lung transplant. And so afterwards, I recognized that we as care partners can be this like army of people who can support, because I saw the staff. I mean, they were heartbroken. They were almost as bereft as we were but they're called in so many different directions. It's like, okay, we can be trained, just tell me what to do and I'll pitch in. So I founded the Care Partner Project, which has, dozens of checklists for care partners so that they know, and it's very much focused on patient safety. It's how do you prevent infections? What are the small things you can do to prevent infections, to prevent falls, to help prevent blood clots, whatever, not to take the place of staff, but to support all those small things that they might not be able to get to, and you're there. I could have
Yep.
been wiping down bed rails watching CNN with my dad every day. He wouldn't have had the infections. So now we offer all of these resources to hospitals so that they now are loading them on their websites to share. And we have an implementation guide that speaks to the issue of, how do you do that meet and greet? And how do you engage your staff to be supportive? And of course, I'm going to use your video. That just supports everything we say, but you say it so much better. And so I just thought that I would throw that out there for all of you care partners. Go to the carepartnerproject.org. And if this is a fit for your hospitals, please. I've been there and I just felt I had to do something. And all of our resources have been vetted and tested in hospitals for over 10 years. So
Great. Thank you, Karen. That was great work. And sorry to hear about your father, but.
Well, you know what? I feel like sometimes the universe works in strange ways.
Yeah, that's true.
We thought he had a second chance at life, but, maybe it was meant to share lessons.
Yes, but what you took from that experience and created an organization is amazing. So great work. Bart, yes.
Yeah, I wanted to really make sure, and it's already in the chat, but I want to verbally acknowledge, what Lisa and Shane shared. Though all of the work, and it's a little different, but then there's a thread line that links the two together, is the ability to have your voice heard, right? And whatever that process is, even if it's here where we're saying, oh, raise your hand and then you speak, right? How do we ensure that we have enough cultural humility to hear each person's voice, right? I love the training. And, as a caregiver, my son is now 22, but when he was in the NICU for the first 3 months of his life, I knew enough about him before he was born that I want to hear, you need to hear my voice, right? I need to be an advocate. And I can, the way you treat me will also determine his health outcomes, right? And so I love what Lisa and Shane and y'all are doing. And what's interesting is that I came here from another Zoom that was all about what matters to you. And that's a global movement. And I think one or two people were on that call too that are here in this one. And I love that. It's a simple thing, right? If I'm at the bedside for my loved one, simply ask me what matters to you. And I'll tell you, right? And hopefully that's a way that we partner as just good human beings, right? And so I just want to share that, and I just wanted to give Shane and Lisa some, their flowers before we end up logging off of here. So good work, and really appreciate y'all. Oh, and if you didn't see in the beginning, so I am also, well, yeah, today, the chair for the FACT, Family Advisory Council for Morgan Stanley.
Bart, that was wonderful. I don't know if you know Alex Zavala, but he's a NICU dad too, and he's on this call. Yeah, he's great. All right. Oh, it's 12:56. We're getting to time here. Matt, can you pull up the slides? Thank you so much. Thank you, Shanne. Thank you, Lisa. It was amazing. Thank you all who's asked questions and given some information. Sorry we didn't get to this more. Maybe we need to do a second one on this. I don't know. So this came from Lisa. What is one thing you want to start doing in your everyday interactions with caregivers? So it gives you something to reflect on as you come out of this session. Next slide. So there's a lot of different resources that are available to you. And these are some of the resources that were kind of referred to within the within the session today, within the conversation today. So we have the Better Together Toolkit, we have patient family roles in safety, we have Safer Together from the National Steering Committee for Patient Safety, from the Institute for Healthcare Improvement. We have the toolkit that people mentioned. Next slide. These are just some of the resources, the references, excuse me, that that Lisa presented in some of her slides. Next slide. And then, so we've already talked about this a little bit, but healthcare excellence in Canada is amazing. And the Ontario Caregiver Organization is amazing. Lots of great tools. On our website, we have Better Together profiles of some exemplary hospitals, so you might want to check them out. Johns Hopkins is included on that. MUSC Health, Michigan Medicine, and then Johns Hopkins Medicine, which we hope we get a profile to include on that. Anjali, do you have a quick question or comment?
Oh, hi, everyone. Just really quick. I just shared a link in the chat. I have not personally watched this yet, but it's a documentary I heard about specifically on caregivers, and it's produced by Bradley Cooper, who we all know. So,
oh, yes, I heard
if anyone
about
wants to check that out, yeah.
Yes, I did hear about that. It's on PBS.
Yes.
Okay, next slide. So I'm hoping that most of you are members of PFCC Connect. It's our free online learning community. If you're not a member yet, we encourage you to join, and you can register and access great information, resources, patient and family-centered care on patient and family-centered care. You can post questions. People will respond to that in the network. You can learn from others, share great ideas and resources, and we can continue this conversation. So next slide. We do ask that you complete the evaluation survey. So these results we do use to help us improve our conversations. I know this one went a little bit over time in presentation. We didn't get to everybody's comments in chat, but you can use the link that's here. And Bev, can you include the link in the chat? Or did you? Oh, you already did that. Okay. Or you can use the QR code. And we'll also share the link when we do the follow-up email. Next slide. Finally, we're hosting the next informal conversation in September 2025. We're just waiting to make the date and the topic to be determined. I'm almost feeling like we should continue this conversation, by the way. The recording the slides and the chat will be posted on the site. And if you have resources that you shared in the chat and you want to share it to everybody, please just email them to me, mabraham@ipfcc.org, and continue the discussion. And so with that, I just want to thank everybody. We went 1 minute over time, so thank you all for joining us today.